Hello, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's topic of discussion is the classification and surgical management of head injury. In the end, please subscribe to our channel and give us a like if you find the lesson useful. So, now here we go. Head and brain injuries are the leading causes of death and disability in persons aged less than 45 years. Acquired head injury or brain injury is a set of injuries that involve the scalp, skull, brain, and underlying tissues and blood vessels in the head. Acquired brain injury does not include lesions of the brain resulting from neurovascular disorders like a stroke, Parkinson's disease, and multiple sclerosis. The scalp injury results from blunt forces, resulting in a tear or crushing of the scalp skin and underlying tissues. Because the scalp is a stressed skin tissue on a hard bone, it is more prone to laceration. Blunt or penetrating trauma to the head can cause significant blood loss from the densely vascularized scalp tissue. Bleeding can be controlled by direct pressure. Simple lacerations should be copiously irrigated and closed primarily. Long lacerations or lacerations having multiple extensions need debridement before closure. For secure closure and better hemostasis, the galea should be carefully reapproximated. Crush injuries with subsequent tissue necrosis require debridement and advancement flaps to cover the defect. The scalp is made up of 5 layers. These are skin, subcutaneous connective tissue, galea aponeurotica, loose areolar tissue, and pericranium, which is the periosteum of the skull bone. The skull fracture may be diagnosed by a skull X-ray or head CT. If the skin is intact, the fracture is called closed. A closed skull fracture does not usually require surgical treatment. If the skin over the fracture is breached, it is called open or compound. Open fractures may be depressed or non-depressed. Non-depressed open fractures only require repair of the scalp and operative debridement. Depressed skull fractures are usually compound fractures and cause a high incidence of infection, neurological deficit, and late onset epilepsy. A depressed skull fracture needs elevation if the depression is greater than the skull thickness, especially where intracranial air is present, indicating a breach in the dura mater. Fractures that disrupt meningeal arteries can cause an epidural hematoma formation. In the anterior cranial fossa fracture, there may be cribriform plate fracture causing a CSF leak from the nose or CSF rhinorrhea, subconjunctival hemorrhage, anosmia or loss of smell due to olfactory nerve injury, loss of vision, either partial or complete due to optic nerve injury, and diplopia or ptosis due to oculomotor nerve palsy. Periorbital ecchymosis after an anterior skull base fracture is known as raccoon's eye. In the middle cranial fossa fracture, there may be maxillary or sphenoid sinus fracture causing epistaxis. A temporal bone fracture can injure the facial or vestibulocochlear nerve, resulting in vertigo, ipsilateral deafness, or facial paralysis. Sometimes a temporal bone fracture communicates with the subarachnoid space and the middle ear and causes CSF leakage into the pharynx via the Eustachian tube or from the ear. The latter is called CSF otorrhea. Ecchymosis behind the ear due to extravasation of blood after a temporal bone fracture is known as battle sign. Subtle CSF leakage mixed with blood can be differentiated by the halo test. If this test is ambiguous, the fluid can be tested for beta 2 transferrin, which is exclusively found in the CSF. Most CSF leaks heal with elevation of the head end of the bed for several days. Posterior cranial fossa fracture can lead to glossopharyngeal, vagus, or spinal accessory nerve palsies and a bulky swelling behind the neck. Linear undepressed fractures of the skull vault are managed conservatively. Traumatic cranial neuropathies usually can be managed expectantly. Fractures that involve the air sinuses are generally managed as open fractures. Blind nasogastric tube placement is contraindicated in these patients. A skull-base fractures may be associated with pituitary dysfunction, arterial dissection, or cranial nerve palsy, such as anosmia, facial palsy, or hearing loss. Non-resolving facial nerve palsy may be taken up for surgical decompression of the petrous part of the facial nerve. ICD-10 diagnosis code for a skull fracture is SO2.91XA. Closed head injury is the most common type of traumatic brain injury. In closed head injuries, there is no penetration or fracture in the skull. It is caused by a rapid forward or backward movement and shaking of the brain mass inside the bony skull that results in bruising and tearing of brain tissue and blood vessels. Types of closed head injury include concussion, contusion, and diffuse axonal injury. A cerebral concussion is a functional disturbance rather than a structural injury. It is a clinical syndrome characterized by immediate and transient alteration in brain function, including alteration of mental status or level of consciousness, especially amnesia of the event. Deficits resolve over minutes to hours. The head CT is normal. Concussion injury is graded by the Colorado grading system. Only confusion is grade 1, confusion with amnesia is grade 2, and loss of consciousness is grade 3. Studies reveal that the brain remains in a hypermetabolic state for up to a week after injury. The ICD-10 diagnosis code for concussion with loss of consciousness is S06.OX9A. A contusion is a bruise of the brain caused by the breakdown of small blood vessels and extravasation of blood into the brain tissue. These are scattered areas of bleeding on the surface of the brain rather than coherent blood clots, seen most commonly along the undersurface and poles of the frontal and temporal lobes. These appear bright on CT scans. Contusions of the brain are most commonly seen adjacent to rough bony surfaces, such as at the inferior frontal lobe and the anterior inferior temporal lobe. During the first 48 hours, they may enlarge or progress to frank hematoma. Progression of cerebral contusions occurs in up to 75% of patients with traumatic brain injury. Edema may develop around a contusion causing a mass effect. Co-contusions are brain lesions at the site of impact, whereas counter-coup contusions occur in the brain tissue opposite the site of impact due to the deceleration of the brain against the skull. Counter-coup contusions are almost twice as likely to progress than coup contusions. Contusions rarely require surgical exploration but may need delayed evacuation to reduce the mass effect. The ICD-10 diagnosis code for contusions of the brain with loss of consciousness is S06.339A. Diffuse axonal injury is a type of primary brain injury resulting from shearing and rotational forces acting on white matter fiber tracts and is most commonly seen after a high-speed vehicular accident. This lesion is the most significant cause of morbidity in patients with traumatic brain injury. It causes damage to axons throughout the brain, which usually makes the patient comatose. Axons may be completely destroyed and then retract, forming axon balls. In more severe cases, multiple petechial hemorrhages can be seen, especially on MRI, classically in the corpus callosum and the dorsolateral midbrain. Usually patients present with bilateral neurological deficits affecting the cerebral cortex, corpus callosum and dorsolateral rostral brainstem. Because of brainstem involvement, autonomic symptoms may be prominent. Diffuse axonal injury or DIE is a frequent cause of persistent coma in patients with head injuries. It is especially a pathological diagnosis made post-mortem. The CT head often appears normal. A normal CT scan in a comatose head injury patient is a classical finding in diffuse axonal injury. Magnetic resonance imaging is the study of choice in diagnosing diffuse axonal injury. ICD-10 diagnosis code for diffuse traumatic brain injury is S06.2X0A. A penetrating brain injury is a wound in which a sharp weapon or projectile perforates the skull and breaches the dura and meninges. A skull X-ray and CT scan should be used to assess the nature of the injury. A cerebral angiography is indicated if the object passes near a major artery or dural venous sinus. The treatment consists of operative exploration to remove any object peeping out of the cranium, debridement, irrigation, hemostasis, and definitive closure. Full antibiotic coverage is given to decrease the risk of meningitis or abscess formation. Traumatic intracranial hematomas may be epidural or extradural, that is between dura mater and skull, subdural, that is between dura mater and arachnoid, and intracerebral, that is subarachnoid. These can expand rapidly and form a tumor-like mass, which compresses part of the brain and increases intracerebral pressure, resulting in brain shift and subsequent herniation. Emergent neurosurgical evaluation and intervention often are necessary. The ICD-10 diagnosis code for traumatic hemorrhage of the cerebrum unspecified is S06.360A. The epidural or extradural hematoma is the accumulation of blood between the skull and the dura mater. It occurs usually due to tearing of the middle meningeal artery after a fracture of the temporal bone and may evolve rapidly. But it may also result from a rupture of a vein or a venous sinus in association with a skull fracture. Extradural hematoma is a neurosurgical emergency requiring a burr hole through the skull to drain the clot and ligate the bleeding vessel. The patient initially becomes unconscious due to a concussion injury. He then awakens and has a lucid interval, headache, but without any neurological deficit. The hematoma expands subclinically, its volume increases, the intracerebral pressure rises as per Monroe-Kelly doctrine, and the patient again rapidly deteriorates, becomes lethargic, and herniates. A mass effect develops with compression of the surrounding brain and a midline shift. Uncal herniation from an extradural hematoma classically causes reduced level of consciousness, ipsilateral pupillary dilatation due to the third nerve palsy, and contralateral hemiparesis. This classical presentation occurs in only a third of cases. On head CT, extradural hematomas appear bright, biconvex, or lentiform hyperdense lesions between the skull and the brain due to the adherence of the dura to the skull. An extradural hematoma is typically found over the convexities but may rarely occur in the posterior cranial fossa as well. The prognosis is excellent if prompt evacuation of the hematoma is done and there is no associated primary brain injury. Patients may be managed conservatively. If the clot volume is less than 30 milliliters, maximum thickness is less than 1.5 centimeter, and the Glasgow Coma Scale score is more than 8. The ICD-10 code for extradural hemorrhage without loss of consciousness is S06.4XOA. An acute subdural hematoma results from an accumulation of blood between the arachnoid mater and the dura mater, that is, between the surface of the brain and the dura mater. Most subdural hematomas are seen over the cerebral hemispheres due to rupture of cortical surface veins. Acute subdural hematoma usually results from venous bleeding due to the tearing of a bridging vein running from the cerebral cortex to the dural sinuses. A stretching and tearing of the bridging veins occur due to acceleration-deceleration of the head because the brain shifts in relation to the dura, which is firmly adherent to the skull. The acute subdural hematoma results through two broadly distinct mechanisms. It occurs not only in patients with high energy severe head injury but also in patients with less severe low energy head injuries, particularly those who are elderly or alcoholic or who are receiving anticoagulants. In the latter group of patients, depending on the total volume of bleeding, the subdural hematoma may present early as an acute subdural hematoma or after a delay as a chronic subdural hematoma, or even may remain clinically silent that may present much later with a further acute on chronic subdural hematoma. Since the dura is not adherent to the brain as it is to the skull, subdural blood freely spreads over the brain surface, producing a crescent-shaped or lunate or biconcave appearance. It does not cross the midline due to the presence of the falx cerebri. The hematoma is extensive and diffuse with rapid deterioration, but there is no lucid interval. Often there is severe primary brain injury and features of raised intracranial pressure, namely high blood pressure, bradycardia, and vomiting. On a head CT scan, the clot appears bright or of mixed density. Bleeds of thickness more than 1 cm or with midline shift more than 5 mm with deteriorating neurological status require urgent evacuation either by craniotomy or craniectomy. Smaller bleeds with a stable neurology may be managed conservatively, at least initially. A chronic subdural hematoma is a 2 to 3 weeks old liquefied clot of blood on the surface of the brain beneath the dura mater. These most often occur in patients aged 60 and above who have brain atrophy due to age or some disease. It is a common cause of acute neurological deterioration in the elderly, especially those who are on antiplatelet or anticoagulant medication. The cerebral atrophy in this age group causes a stretching of cortical dural bridging veins which then become vulnerable to rupture from even a trivial impact. About 25 to 50% of patients have no identifiable history of head trauma. If a patient does have a history of head trauma, it is usually mild. After sustaining a head injury, symptoms develop after 1 to 4 weeks in 25%. Another 25% experience symptoms after 5 weeks to 3 months. Only one third of patients have no symptom-free period. Patients may present with headache, seizure, confusion, contralateral hemiparesis, or coma. After a mild head injury, if a symptom-free patient becomes symptomatic, this phenomenon is referred to as an acute on chronic subdural hematoma. Acute hematomas are bright white or hyperdense on CT scan for approximately 3 days, after which they may fade to become isodense with the brain and then hypodense after 2 to 3 weeks. A true chronic subdural hematoma may be nearly as dark as CSF on CT scan. In a clinically stable patient, drainage should be done 7 to 10 days after reversing the anticoagulation if indicated to allow platelet function to normalize after withdrawal of aspirin or clopidogrel. A simple burr hole can effectively drain most of the chronic subdural hematoma. The subarachnoid hemorrhage is the presence of blood into the subarachnoid space between pia and arachnoid matters. It may be spontaneous or following trauma. But the most common cause of subarachnoid hemorrhage is head trauma. The diagnosis is confirmed radiologically by computed tomography scan without contrast. But non-traumatic or spontaneous subarachnoid hemorrhage usually occurs due to a ruptured cerebral aneurysm or an arteriovenous malformation. The traumatic subarachnoid hemorrhage is not usually associated with significant vasospasm, which is a characteristic feature of aneurysmal subarachnoid hemorrhage. The signs and symptoms of subarachnoid hemorrhage are from subtle prodromal events to the classical presentation. The most common symptoms are severe headache in 50%, vomiting, confusion, dizziness or vital pain, diplopia, loss of consciousness, and loss of vision. The possibility of a spontaneous subarachnoid hemorrhage that leads to collapse resulting in a head injury should always be kept in mind, and a CT angiography should be ordered to exclude this. The management of subarachnoid hemorrhage is conservative or medical. Arterial dissection after head injury. An arterial dissection refers to a tear in the vessel wall intima. The extracranial internal carotid artery is affected in 75% of patients, usually 2 cm distal to the bifurcation, and the extracranial vertebral artery is affected in 15% of the patients. The blood gets in the tear between the intima and the media, within the media, or between the media and the adventitia, and separates the layers of the arterial wall. The expansion of the hematoma within the vessel wall leads to narrowing of the original vessel lumen and reduction or cessation of distal blood flow, resulting in focal ischemic deficits. The vertebral artery dissections may result in subarachnoid bleeding. Headache, neck pain, and focal neurological deficits are usual clinical features. 4-vessel cerebral angiography should be performed when there is a suspicion of arterial dissection after head trauma. Surgical or interventional radiological techniques are used to manage this condition. The surgical options are vessel ligation and bypass grafting, and interventional techniques include stenting and vessel occlusion.